In this last part, we will examine a few more causes of arrhythmic syncope. This young patient presented with syncope. Why might that be? Pause the video and have a look for yourself. You can see that the QRS begins very shortly after the P wave, giving an apparent shortening of the PR interval. If we examine the initial portion of the QRS just after this P wave, it looks like a little triangle has been added to the QRS. This is called a delta wave. Let's look at another ECG. Can you see an abnormality here? Again, you can see a delta wave, and coincidentally, it's also best seen in V4 here. Specifically, the delta wave is defined as the first 40 milliseconds, or one small box on an ECG, to delineate it from the rest of the QRS. Let's look at a slightly trickier one. Again, pause the video and have a look and see if you can identify the abnormality. This patient also has a delta wave, but this one is negative. See, delta waves can be negative as well as positive. When they are negative, they can often be confused for Q waves. This could mislead the reader to think that the patient had an old myocardial infarction with pathological Q waves, which can often be markers of old heart attacks. In this case, it is a negative delta wave and merges with the P wave. So what is the significance of this delta wave? Well, it's a marker of an electrical abnormality going on inside the heart. So what is this electrical abnormality? Well, in embryological development, all connections between the atrium and the ventricle should be destroyed, leaving only the AV node connecting from the atrium to the ventricle. But in these patients, an extra connection remains and is not destroyed. This is atrial myocardium and this is ventricular myocardium, and this is the mitral valve. And here you can see just a few muscle cells bridging the atrium to the ventricle. So now you have two connections from the atrium to the ventricle. This accessory pathway or bypass tract, it's bypassing the AV node. So you have your accessory pathway and you also have your AV node. And so why is this a problem? Well, the AV node is designed to be the only connection because it has special filtering properties that protect the ventricle. For example, it protects the ventricle when the atrium goes really fast. It doesn't let all those impulses conduct through to the ventricle because that can be dangerous. Having two connections, the AV node and the accessory pathway, can allow extra circuits or rhythms to form. You may have heard of this as atrioventricular reentry tachycardia, or AVRT. And that's illustrated here in these two pictures. So essentially, it's an endless loop going down one and up the other, or the other way around. In orthodromic AVRT, it goes the correct way through the AV node. In antidromic AVRT, it goes the wrong way through the AV node. So in antidromic AVRT, it goes up the AV node, activates the atrium, goes down the accessory pathway, activates the ventricle, goes back up the AV node, activates the atrium, and it carries on in an endless loop. In orthodromic AVRT, it does the exact opposite. It goes ortho, the correct way down the AV node, and the wrong way up the accessory pathway, and that carries on in an endless loop. Then there are pre-excited arrhythmias, and this just means whatever atrial arrhythmia is happening, it's going down to the ventricle using two paths. It's going down both paths. So in sinus rhythm, it goes down the AV node as normal. Then the delta wave is created by it being pre-excited through the accessory pathway. But this could also apply to very fast atrial rhythms, such as atrial fibrillation or atrial flutter, which normally the AV node would filter out a lot of those impulses, but the accessory pathway may not, and that may be dangerous. Here we have an illustration of pre-excited sinus rhythm. The sinus node activates the atrium, the P wave that is. The atrial activation activates the AV node, which then passes on to the ventricle. But also, in parallel, the accessory pathway is also activating the ventricle from another part, and that's where the delta wave comes in. So these connections can either be unidirectional or bidirectional. If they're unidirectional, they may allow conduction only in the retrograde direction, that is, from the ventricle to the atrium, and not the other way. Or they can be in the antegrade direction, that is, from the atrium to the ventricle, and not in the opposite direction. Now, the delta wave that we saw on the ECGs previously is termed Wolff-Parkinson-White pattern and indicates an antegrade conducting pathway. Okay, that is allowing the ventricle to be activated through the bypass tract or accessory pathway from the atrium. A retrograde only conducting pathway cannot be seen on a sinus rhythm ECG. And so its presence is termed concealed or hidden. Here we have atrioventricular reentry tachycardia or AVRT inducing atrial fibrillation with pre-excitation. Without an accessory pathway, atrial fibrillation does not often result in very fast ventricular activation because the AV node filters out some of these impulses. The accessory pathway does not possess these filtering properties and therefore permits fast ventricular rates. Here we have very fast pre-excited atrial fibrillation. It almost looks like polymorphic ventricular tachycardia or ventricular fibrillation, but it's not. But this can degenerate into ventricular fibrillation and cause sudden cardiac death. Electrical cardioversion returns the rhythm to a pre-excited sinus rhythm. So here we can see a shock is given here and it returns to sinus rhythm, and that delta wave can be just about seen there. This is a nice summary ECG which shows AVRT triggering pre-excited atrial fibrillation, which then triggers ventricular fibrillation. This nicely highlights the danger of accessory pathways and the importance of the delta wave or Wolff-Parkinson-White pattern on ECG, especially in patients presenting with syncope. A patient presenting with syncope may only present in sinus rhythm. You may only see this portion of the ECG, when really this is what happened a few minutes prior, and this is what caused their syncope. But it is unlikely that you will see this again during a period of observation. So it is important on the basis of this part of the ECG that this part is inferred. It is important to point out that AV node blocking drugs such as beta blockers or cardioselective calcium channel blockers like verapamil or diltiazem can impede the AV node but leave the accessory pathway untouched, which increases pre-excitation. Here's an example of somebody given calcium channel blocker, which blocks the AV node, in this case verapamil, showing more pre-excitation, more delta waves after the drug than before the drug. And so alone, these should be avoided. So how do we risk stratify these patients with delta waves or Wolff-Parkinson-White? Here we have somebody with Wolff-Parkinson-White, as I think you can see. There are P waves, and every QRS that follows has a short PR and a delta wave. The heart rate here is around 60 beats per minute, so the P waves are occurring at around a rate of 60 beats per minute, and each one of them is pre-excited. That means that at 60 beats per minute, the accessory pathway is excitable when the next P wave occurs. It can pre-excite it. It's had enough time to repolarize to pre-excite the next P wave. Speed up the heart rate. How does that accessory pathway respond? So here we have sped up this patient's sinus heart rate by exercising them, which means you're asking more of the accessory pathway. You're asking it to pass on the impulse at a shorter time interval. In this case, the heart rate has increased to 176 beats per minute, which means the pathway and the AV node need to become excitable again after 340 milliseconds. The AV node performs this reliably. All the P waves result in a QRS, though the accessory pathway does not achieve this. At this rate, only the AV node is conducting from the atrium to the ventricle. This indicates the refractory period of the accessory pathway. So here we can see all these are pre-excited, they have delta waves, and now they all become narrow. They lost their delta wave, which means the accessory pathway is not contributing to these QRSs. It can't keep up with this rate as the heart rate has sped up. When the accessory pathway can keep up with very fast heart rates, then it is more likely to be dangerous. In fact, there's a number that we look for. We measure the shortest pre-excited RR interval, and those under 250 milliseconds confirm a higher risk of sudden cardiac death. Here's an example of two QRSs that are both pre-excited, which means the accessory pathway is working for both. That means it can repolarize and be ready and excitable within 250 milliseconds. That is 240 beats per minute. That means it can sustain very fast rhythms and makes it more likely to be dangerous. So what are the key management points for Wolff-Parkinson-White? Well, electrical cardioversion, of course, is warranted in ventricular fibrillation and also in pre-excited, unstable atrial fibrillation. AVRT, a type of supraventricular tachycardia, or SVT, will often respond to vagal maneuvers. And if they don't work, then adenosine and electrical cardioversion will work. In contrast, stable pre-excited atrial fibrillation will not respond to vagal maneuvers. However, procainamide infusion will impair the accessory pathway to make atrial fibrillation less pre-excited and therefore safer. If they are normal sinus rhythm with a normal heart, then flecainide tablets can be given as an outpatient to limit the accessory pathway's activity. This can be coupled with a beta blocker, but beta blockers alone should be avoided, as we pointed out. Finally, referral to cardiac electrophysiology for an electrophysiology study or EP study and ablation should be offered, especially in syncope patients who present with Wolff-Parkinson-White, that delta wave on an ECG. As a short aside, most supraventricular tachycardias, SVTs, respond to vagal maneuvers because to break the rhythm, you only need to break one cycle of it. This can be done by blowing into a syringe for 15 seconds before lying back with feet held high in the air. This is called the modified Valsalva maneuver. So why are beta blockers given in addition to antiarrhythmic drugs like flecainide? Flecainide is an antiarrhythmic drug which slows the rate of atrial flutter to a rate which potentially the AV node can conduct one-to-one. For example, without flecainide, the AV node may conduct half or 50% of the atrial flutter beats at 300 beats per minute, yielding a ventricular rate of 150 beats per minute. This is typically seen in atrial flutter, that rate, around 150 beats per minute. By slowing the atrial flutter rate to 200 beats per minute, resulting from the administration of flecainide, the AV node can now conduct one-to-one, ironically yielding a faster ventricular rate of 200 beats per minute. Giving a beta blocker prevents this fast ventricular rate. These are called 1C flutters because flecainide is class 1C in the Vaughan-Williams classification of antiarrhythmic drugs. Here we see a one-to-one flutter, which conducts aberrantly, so it's got a broad QRS and looks like it could be VT, when in fact it's not. When this patient is given a beta blocker, then it slows down and the QRS becomes narrow again. Here we have a wide complex tachycardia. In fact, this is ventricular tachycardia from a 68-year-old man presenting with syncope. What might be causing this? There are well-defined criteria to diagnose arrhythmogenic ventricular cardiomyopathy. This includes imaging with an echocardiogram or MRI, the option of sampling some tissue. Here's a bioptome grabbing some heart muscle inside the right ventricle, which can be looked at under a microscope slide. But in fact, most of the diagnosis is based on the ECG and history. So let's have a look at these. So here are some of the ECG clues that this is arrhythmogenic ventricular cardiomyopathy. What we have here, indicated by the black arrows, is the presence of epsilon waves. These are little fractionated signals after the end of a QRS. The QRS begins and ends, and then after that, there's this little blip, very subtle. You have to look closely for it. And that's called an epsilon wave. A second clue is the T wave inversion across multiple leads, V1, 2, 3, 4. This is unusual. And a third clue is a broad S wave greater than 55 milliseconds. That's around 1.5 small boxes at the end of QRS. It's called terminal activation duration, greater than 55 milliseconds. That's seen here. These are clues of arrhythmogenic ventricular cardiomyopathy. And here we see an ECG, a sinus rhythm, and an ECG, and ventricular tachycardia. Together, they're evaluated against a scoring system to estimate the likelihood of arrhythmogenic ventricular cardiomyopathy as a cause. So we look for things like anterior T-wave inversions, which we've looked at before, the QRS duration, notching in multiple leads in VT, and where it transitions from negative to positive. Arrhythmogenic ventricular cardiomyopathy is a genetic disease, and unfortunately, intense exercise and prolonged exercise worsens the progression of the disease. So these patients with known AVC are advised to limit their exercise and abstain from competitive or intense or prolonged exercise. The key to managing AVC is to recognize it and monitor the degree of heart failure over time. This will normally be done by a cardiologist, but recognition that they can have syncope due to ventricular arrhythmias is important. And they can also have progressive reduction in exercise tolerance as their ventricles fail. Medical management with beta blockade helps prevent ventricular tachycardia, and a defibrillator is warranted in those who've had syncope, likely due to VT. And like all genetic diseases, they need genetic counseling and testing, and so do their family members as needed. Normally, they'll be managed by an electrophysiologist and a heart failure doctor, as well as a general cardiologist. Cardiac syncope is a small portion of all the causes of syncope. We have seen quite a few of these causes today, and it's important to recognize that these cardiac causes of syncope have a much worse prognosis than the non-cardiac causes. It's also important to recognize that in nearly all the cases we've examined today, there are clues. Those clues are either on history, physical, or ECG, which is why those three things need to be done in every syncope presentation. In terms of ongoing tests, rhythm monitoring with either a Holter as an outpatient or telemetry monitoring as an inpatient can be done, and imaging with a transthoracic echocardiogram should be done, and a cardiologist will help advise you as to whether these should be done as an inpatient or an outpatient. I hope that you have found this presentation helpful, and I wish you all the best.